Good morning. So glad you joined us. This is the favorite part of the week for me, and I'm glad you're here with us on this Saturday morning. If you guys are regular listeners, you know that I am just fascinated with the human brain. There's 3 pounds of fat up here between your ears. It's really remarkable. And the more we've learned about what it does, how it grows, how it develops, and what happens when it's injured, the more interesting it becomes. Our brains are really fairly delicate creations. Our bodies just weren't built to cope with the kind of G-forces that can happen today in modern sports, traffic accidents, on-the-job injuries, and that kind of thing. And we're learning a lot more about what happens when you have one of these mild traumatic brain injuries, which are also called a concussion. So we're going to talk more about today about concussions. As kids are getting back in school and sports are on the increase, that's a concern. And so I brought into the studio some specialists on concussions from Midwest Concussion Clinic. That's a new service by the Doctors of Physical Medicine Consultants. We have one of those doctors with us today, Dr. Tom Lazoff. Good to have you back again.
Good morning. Thanks for having us again.
And also with us today is the clinical director of the clinic, Matt Campbell.
Thanks for having me as well.
You bet. Tell me something I don't know about concussions.
I think one big thing would be that you don't have to hit your head to have a concussion.
Oh, tell me more about that.
So your brain is in your skull, and it fits in there, but there's space on all around the brain. So, and what we'll talk about probably a little bit with Matt is that, the brain moves, even with a helmet and protection, the brain is actually moving in your skull. And so you could be in a car accident, you could, have a tackle and not necessarily really hit your head per se, or be helmet to helmet, but the brain is moving and there's shear forces that take place. And then those forces damage neurons in your brain, and consequently you can have a mild concussion.
People don't have a chance to look inside the skull very often, but it's not a smooth surface in there. There's lots of danger points for that brain as it's sloshing around.
Correct.
And so what happens in a concussion? Is it a bruise? Is it a tear? What's going on inside the brain?
So the old school thought with concussions is it's a bruise, right? So it was the brain sloshing forward, hitting the front of the skull, sloshing to the back of the skull. Now that we understand more of what concussions are, we look at it less as a bruise and more as a shearing injury inside the inner structures in the brain. So that being said, anytime you slide forward or backwards, the brain slides on the inside, and it's almost like it's sliding and pulling apart at a very, very small molecular level. That increases, the changes inside the brain with the electrical system, the hormones that are in the brain, the nutrients moving in and out of the cells are all affected by the shearing force inside of the brain.
I didn't think about that. So you're really affecting the electrical flow through the brain.
Correct.
Interesting. Tell me some of the things about how thinking has changed over the years about concussions. You just said we no longer think it's a bruise, but what else has changed?
So as we get more and more research into this, technology improves, research improves, we're able to understand kind of what the brain does. One of the early thoughts is we know about 1% of what the brain is. Well, now over the last 18 months, we now think we know about what 2% of the brain does. So they're starting to understand that the movement inside the brain, the changes in forces Doc talked a little bit about, is not hitting your head that's necessarily the problem. It's the jostling forward and backwards. We start to look at the injury as a whole and how complex it really is. It's not just a bruise on the brain that needs to fix. It's a shearing injury that affects the electrical system, which in turn affects your autonomic system, your heart rate. It affects your mood disorders and your psychological changes. It affects cardiopulmonary changes inside the body. It's a significant injury that affects every part of the human body, not just the brain itself.
So we often associate concussion with football, but what is the sport that generates the most concussions?
We were talking about this earlier. Volume-wise, it would be, in the United States, would be football. Mm-hmm. Rugby players also have a high incidence of, concussion or mild traumatic brain injury. But we've seen people from an athletic perspective from all sports, from soccer to cheerleading, which are low on the list, but we've seen all of that, to wrestlers. Wrestlers have a higher instance as well. But in the United States, it would be football.
Mm-hmm. Outside of sports, I'd assume traffic accidents are the leading cause. After that, what are we seeing concussions from?
Basically, people having altercations, slipping and falling is the a very common one, especially as we get a little bit more mature, our balance issues aren't as up to par, and consequently we fall. We have odd and end sorts of things. I mean, there's some interesting ones that have occurred out there.
On the job injuries.
On the job, yeah.
Yeah, all those kinds of things.
Unfortunately, domestic violence is one of the big ones. It's one of it's hard, for good reason. It's hard to get research into that realm, but one of the most prevalent that they're starting to see outside of sports is that domestic violence.
Yeah, that makes sense. So, what are some symptoms that I need to look for if I'm a parent that might not be obvious? Because my kid may not come home and say, yeah, I took a pretty good hit today. I mean, often athletes don't want to admit that they've had a concussion, right?
That's correct. I mean, some of them might be that they're sleeping in later, or, just not getting off the couch as often, having a headache, missing school. Grades are starting to falter. Might even lead to drug use or a medication usage that's not prescribed, or might be some of them as well.
Yeah. And a lot with parents, it's easy for them to see changes in mood and behaviors outside of the normal. When you deal with the teenage population, your hormones and moods are going to be up and down and up and down, so you get kind of a consistent flow on what we expect for our athlete or my child, right? But when they sustain a concussion, their body's trying to re-regulate hormones, re-regulate their mood, and trying to even themselves back out. So you may notice significant spikes in changes of behavior, whether that's anger that's out of nowhere or unprovoked, or it's sadness or agitation, that may involve, you talked a little bit about it on the intro with the prevalence of getting into a physical altercation.
Right.
So a lot of the big ones may not necessarily be something that they'll tell you, but you'll notice confusion. They'll walk into a room and kind of like, as we get older, we all walk into the room and forget why we're there. But generally it doesn't happen for younger people, right? So if you start to notice that, I forgot why I'm in here, or you asked me to do something and, I looked at you and I understood and I agreed to do that, but as soon as I left the room, I can't remember what we did or why I said I would do that. So a lot of them are just going to be what parents notice that are not normal.
So I have read, Tom, you said a moment ago, Dr. Lazoff, you just said that you don't have to hit your head to have a concussion. You also don't have to lose consciousness in order to have a concussion.
Correct.
And I've also read that you can have symptoms that will appear weeks, even months after the incident, after the impact. That's shocking. So how would you know that's a concussion? If I'm feeling maybe dizzy would be pretty obvious, but sleep disruption, I can't focus, I've got light sensitivity, what would lead? There are a million different things that could mimic a concussion.
Correct.
So how do you diagnose? How do you know that that's what it is?
The first step is obviously, like you said, to make sure it's a concussion. So there are times where individuals, and especially athletes, have an injury, and consequently you need to make sure, that then Matt's very good at this. Well, is it an allergy? Are they having allergies that's causing this? Is it so? A good physical examination and history is imperative, and then going from there, then that's where Matt's expertise is exceptional in evaluating the different parts of the brain from the standpoint of puts them through vision, puts them through cardiovascular exercises, etc. Are important.
Yeah. I think that's a big part of where our clinic differs, right? So our initial evaluation averages anywhere from an hour and 15 minutes to an hour and a half. And a lot of it is just sitting down, talking with the kid, talking with the parents, talking with the individual that came in through workers' compensation, or, somebody who fell, getting a detailed history of well, I don't think I hit my head. I don't remember hitting my head. Okay, well, we already established that doesn't have to happen. But, taking somebody who's complaining of the dizziness, the confusion, I'm having more memory problems. I just don't feel normal. That's what we get a lot is I don't feel normal or I feel off. Because when you have a concussion, it's difficult to explain how you feel. If you're explaining to somebody who's never had one or is not a concussion specialist, it's hard to sit there and say, okay, I'm having difficulty concentrating. I can concentrate for 10 minutes, but then I lose it, or at work I'm able to perform for the half the day, but the second half of the day I'm shot and I'm no good. So a lot of times they describe it as I'm off. So it goes through our evaluation that we have to sit there and look at, why are you off? Explaining that it's difficult to explain how I feel. To me, I hear it all the time. So I get patients that'll say, people think I'm crazy when I say this. Now this is what we deal with. We hear it all the time. So providing the area of it's okay to say I'm not right, or it's okay to say I don't feel right, and then letting us do our evaluation and gain what that means.
And I think it's also important to note that there's not really a mainstream test, diagnostic test from like an MRI, CT scan that is going to tell you that somebody has had injuries to their neurons. And so there, research is obviously, like Matt said, there's a lot of research occurring. There's going to be blood tests eventually, or types of fluid tests to see who's at risk for a longer recovery period, et cetera, for traumatic brain injuries. But an MRI or a CT scan outside of the acute setting, if somebody did really hit their head and they were knocked out, and making sure that they don't have like a hematoma or a blood clot on the brain.
Right, yeah. And we are back to a discussion about concussions with Dr. Tom Lazoff and Matt Campbell from the Midwest Concussion Clinic. You'll find them online at mwconcussion.com. So we've talked a little bit about what they are, the dangers involved. How do you treat a concussion? The old way of thinking was, just go home and get to sleep.
Correct. That has changed. That philosophy has changed due to research. And I'll let Matt talk about that. I would just say that we want to minimize medications. That also was like a knee-jerk reaction. Let's put somebody on low-dose antidepressants at night to help with their headaches, to help with sleep, etc. When we now know, especially in young people, that is not a great idea. With everything that's coming out in the literature with medications and their effect on the body. So this is where Matt's expertise is, awesome.
So let me take a stab at headaches here. If I've got a post-impact or post-injury headache, is it safe to take aspirin, ibuprofen, those kinds of things?
It's safe to take them, but you need to, if you're just taking, a little bit here and there every other day, or maybe on a rare occasion, but if you're taking them around the clock, then you'll end up getting potentially rebound headaches, and so your headaches will come back stronger and harder after every time the Tylenol wears off or the Motrin wears off. And obviously those medications, especially as we get more mature, are not the safest for you either, right. As far as anti-inflammatories are concerned. And so and then if somebody does have a headache, it could be coming from their neck. If they had an injury or an event that occurred that caused them to have a mild concussion, then you also need to make sure that you're ruling out stuff from their neck causing issues as well. Yeah,
and think about that, the biomechanical side of the injury. So Matt, what do you do? How do you treat me?
So early intervention's key, right? So we want to evaluate somebody who's sustained an injury or suspected that they sustained an injury as early as possible. The earlier that we can get in and do our evaluation, the better the outcome is, and the more likely that they don't develop persistent concussion symptoms, or post-concussion syndrome, which we'll get to. So when we bring them in for the initial evaluation, we put them through different ways of looking at the way their eyes work with their balance system. We look at the way their neck moves. Doc touched on it a little bit about, wanting to make sure to rule out significant structural damage to the neck, but we also want to look in what kind of dysfunction is coming from the neck. Cervicogenic symptoms with concussions are very prevalent. So whiplash injury, it takes half the amount of force to sustain whiplash that it does to have a concussion. So with the concussion, you're always going to have some form of neck musculature that's sore. So we want to look at the differences in the dysfunction inside the cervical spine and inside the neck itself. We look at the way their eyes and their vision systems are working. We want to look to make sure that, if I'm trying to track a target and I think the target's way up on my right, but my eyes are on the left, that's a significant problem that we have to look at. Our eyes don't lie. I tell that to patients all the time. You see it in high school kids a lot, that I'm fine, there's nothing wrong. Well, if I'm telling you to focus on a target all the way on the right side and you can't follow it and focus it out there, your eyes don't lie. So the eyes are a big part of what we look at. We look for the ability to track things back and forth, the ability to look at depth perception by moving objects closer and closer to their face and seeing if they can still see it. And then we try to kind of tie everything together and, okay, now how does the body function right now? We do what's called the Buffalo Concussion Treadmill Test or the Buffalo Concussion Bike Test, where we try to elevate the heart rate in a controlled setting. It's not a sprint. It's not we're not running on a treadmill, but we're walking and slowly increasing speed and slowly increasing the incline or the resistance on the bike and measuring what their heart rate does and where the symptoms come in. Aerobic exercise is a big part of concussion recovery. So trying to regulate blood flow to the brain, trying to regulate the autonomic system, doing aerobic exercise outside of an initial 24 to 48 hour period, 72 hours, depending on which research you look at. The aerobic exercise side of things is a large component of what we're looking to do.
So do you have the ability in any way to look and see what's going on inside my brain and that electrical pattern to see if that's been disrupted?
Yes, we have the ability to perform an EEG, and there are classic waveforms that will pop up to help identify the patients that are still suffering. We don't do it initially with patients because Matt normally gets them better, but there are those few that don't get better, and then we'll do an EEG to document, hey, yeah, you do have you've had a significant concussion. That may be why you're not getting better. And then we go to a little bit more aggressive techniques.
And tell me more about what you can do for me, Matt. What's that therapy? So you've done all that diagnostics. Now what?
So I like to call it concussion therapy, right? There are multiple forms of therapy inside concussion therapy. We've got manual therapy, which is soft tissue work through the cervical spine, upper shoulders. Some people know it as trigger point release or massage. It's all part of manual therapy. There's vestibular therapy, where we look at the balance side of things in the inner ear and the way those work together with your proprioception, knowing where your arms and legs are in space. We do vision therapy, where we're training the eyes to get back on the same page with the brain, essentially going through basic eye movements, basic head movements, to where they sit there and our body goes, okay, I know how to do that, and it starts to speed those neurons back up that are slowed down. And then we do a little bit of cognitive therapy, not necessarily in the traditional sense, but adding short-term memory drills to our balance exercises, to our manual therapy techniques, that we sit there and we're slowly starting to train the brain to refunction the way it should. We in our diagnostic tests early on, we look at, okay, what dysfunction do we have with memory? What dysfunction do we have with concentration? We can add those into exercises to make everything harder. Doing things standing still, the exercise is easy. If I make you move back and forth, the exercise becomes more difficult. If I move the target that you're looking at, the exercise becomes more difficult again. If I make you count backwards from 100 by 7, or stare at a Snellen eye chart and give me every animal name that you can think of that starts with the letter E on the top of the chart, that makes the cognitive side of our therapy intertwined into the rest of the therapy.
So how long typically is it going to take? I guess it depends on the severity of injury, but how soon typically am I safe to get back to activities, and when am I cured, so to speak?
Well, that's actually a moving target on every individual. And so, you also have to remember that there are also external factors, social situations, their home situation, their school situation, that impact their ability to and rapidly progress through the system. So it varies from patient to patient. state of Indiana, from the high school aspect of things, we use the SCAT-5. Mm-hmm. So Matt puts them through the more of a cognitive testing, and in a lot of cases we'll have baseline before they even, before the season started, we'll have a baseline test, so that then when we test them and they've got a significant drop, and we use that, and they take that test periodically to make sure that cognitively they're better and that they are symptom free. And then, like Matt said, the eyes don't lie. So even though they want to get back to playing quickly, we want to make sure that their exam is totally normal before sending them back.
Gosh, guys, the clock has gotten away from us. We got to run. Already, I know.
Right.
Oh, okay.
That is Dr. Tom Lazoff and Matt Campbell from the Midwest Concussion Clinic. It's a service of physical medicine consultants. You can find them online at mwconcussion.com.